Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Cleo Rochat, and I'm joined tonight by Brian Ward and Sydney Engel. Say hi, Brian and Sydney.
Hello!
This is now our fourth installment of the Fables from the Cribside, our show where we review and recap top insights from previous episodes of the show. But first, let's remind you about the show.
We are the Pediatric Medicine Podcast. Usually in this show, we interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
On these episodes on the Fables from the Cribside, instead of a conversation with one expert guest, we're taking a look back at 3 of our prior episodes with a focus on some common pediatric pulmonary disorders. We'll be doing a spaced repetition recap of top pearls about pneumonia, cystic fibrosis, and sleep apnea.
So without further ado, let's get to it.
Let's put on your non-rebreather. It's time for a recap.
All right, so before we jump into the recaps, should we do a quick round of picks of the week?
Sure, Sydney, why don't you get us started?
Oh, I have to go first? Okay, so my pick of the week, I promised I wouldn't do a one for children this week because I've only done things related to children. So this week, my pick of the week is an app called Paprika, which essentially what it does is it takes recipes from online and translates them into something where you don't have to scroll through it and it stays always on and you can click and it moves all the ingredients into a shopping list, and it's literally the best $3.99 I've ever spent. So thank you to my former coworker who introduced me to it. It is game-changing.
Wow.
I love that. I love paprika, especially on deviled eggs.
Okay. Well, I love the sound of not having to scroll in a recipe to understand what to do next.
Your pick of the week.
I think my pick of the week, so we are recording this episode during Nurses Week. And so my pick of the week is just shouting out all the nurses who are super incredible that we work with every day. And I feel like working with the nursing team has been such a highlight of my medical training, and I've learned so much. So just a shout out.
Wow, Cleo, I feel terrible that you. I picked an app and you picked nurses. All right.
From the daily to the sublime to the daily again. My pick of the week is going to be this guy, Ethan Tash. My co-resident, Eric Schneider, who I'll shout out here, put me onto his music. And his last music video is him on a beach in a lobster costume. And it's my vibe. It's what I strive for.
Okay, well, I'm going to have to look that up. It's Tasch.
I had to look this up to make sure I said it right. But yeah, it was like one of those like, he's going to be at this like random place in Nashville. Let's go see him. So I'm very excited. I hope he wears the lobster costume.
Are you going to wear a lobster costume?
I'm considering.
Okay. All right.
Well, on the note of lobster costumes, we forgot to get a pun to transition us for this one, so I'm just going to jump straight into it with our first recap episode, which is episode number 11 on pediatric pneumonia with our guest, Dr. Susan Lipset. It was produced by Maximilian Cruz. I loved this episode. This episode was game-changing for me in terms of just thinking about pediatric community-acquired pneumonia and all of the different elements that go into diagnosing and figuring out the proper treatment. So starting with takeaways, a big thing that Dr. Lipset pointed out was that when you talk about community-acquired pneumonia, you're actually talking about all forms of community-acquired pneumonia and not just bacterial causes. So you also are looking at viral and fungal, and that's really significant because the majority of community-acquired pneumonia in pediatric patients is actually viral. Now, the problem is that we don't have a good way to differentiate between the two. So we have to treat it as if there's a possibility of a bacterial etiology. And when you're looking at bacterial, most pneumonia in kids is going to be caused by either mycoplasma or strep pneumonia.
Yeah, and I have to agree, Sydney. This was, since the beginning, one of my favorite episodes. Just super high yield information, really helpful. The guest was very clear and awesome at explaining pneumonia. And I really like when talking about the patient in front of you, you don't know that you feel like they have pneumonia. You don't know if it's viral, bacterial, or what is causing it, but thinking about patients and if they're not vaccinated completely, which bugs you should be thinking about more seriously, like considering H flu and the need for broader spectrum antibiotics, just given the resistance pattern of H flu to our common antibiotics that we reach for. Can you remind me what some of the symptoms Dr. Lipset discussed when talking about pneumonia? Like, what do we expect to see in these patients when they come into our clinic or emergency department?
Totally. And I think this was one of the areas that was most striking to me, because really what she nailed down on is the fact that while there are signs and symptoms that will point to pneumonia for a patient, unfortunately, they are not so great at independently predicting whether a patient will have pneumonia or a different upper respiratory infection. So yes, a patient may come in with fever and tachypnea, but unfortunately, those symptoms on their own are not independently associated with a bacterial pneumonia. And really, the only signs and symptoms that have been associated are hypoxia and an increased work of breathing.
How about wheeze? What should we think about wheeze?
Oh, I loved this. So the thing about wheezing is that it actually has a negative correlation with bacterial pneumonia, because if you think about it, wheezing is related more to the upper airways. And so when you hear wheezing, you are going to be thinking more about a reactive airway disease picture, and you can actually kind of breathe easier. That seems weird in this. You can kind of say, okay, probably not a pneumonia picture.
Brian liked that one.
It was great. Fantastic.
I didn't mean to. All right. So maybe we can jump a little bit into the sort of testing that is done. Do one of you want to kind of jump in and give your thoughts in terms of X-ray based on this episode?
Yeah, this one was interesting for me because I know there's evidence to suggest, or at least guidelines to suggest, that pneumonia can be a clinical diagnosis. Dr. Lipset talked to what was my practice, which is theoretically it's great to not have to use an X-ray to make that diagnosis. But in practice, especially in the emergency department, you often will rely on that X-ray. It becomes more complicated when you're somewhere like where you practice every day, Sydney, where you might have to send a family out to a different facility to get an X-ray, have to be mindful about what you're putting the family through. And so it was an interesting, to me, tempering of recommendations where you can make the diagnosis without an X-ray, but know that if you have that X-ray, it can be very helpful to rely on it. And you don't have to stray away from X-ray if you have predictive value that you're going to get from that image.
Yeah, I feel like Dr. Lipset just did such a great job at appreciating and acknowledging the nuance that everyone is practicing in different settings, and the access to care is going to drive what you do. And so even though the IDSA guidelines advise against X-ray because it doesn't tell you whether it's bacterial or viral, her point was, well, if you don't have access to X-ray, yes, that makes sense. But if you do, using the X-ray can actually help exclude the pneumonia, because a negative X-ray is pretty darn predictive of a negative pneumonia, and then you aren't giving a child antibiotics who doesn't necessarily need it. So it's really just contingent on the setting that you're working in, what the access looks like, what the follow-up options look like. And I feel like that's sometimes a challenge to be like, okay, this is going to look different in my clinic than it does in yours because of where we're located, because of what it will take for a child to get this type of care.
Yeah, I think that episode really, there's something for everyone in different practices, like you said, Sydney, and just another plug to everyone to listen to the episode itself. Well, we're happy to recap it fully too. Can you remind me if other things that she mentioned about testing in terms of any labs that we should or shouldn't get when evaluating for pneumonia?
Yeah, totally. I mean, I think this is another one where it kind of went a little of both ways, that there is some value to drawing blood, but you don't necessarily want to draw blood on all kids. If you're already drawing blood, you might want to get a procalcitonin, or if you are in one of those practices who happens to have a point of care procalcitonin in an emergency department, yes, that's going to help you distinguish between bacterial and viral etiologies, but not necessarily worth doing a blood draw for it independently, and it's not yet fully incorporated into guidelines. Similarly, a white blood cell count can be useful, but she pointed out that adenovirus, so clearly a viral cause, can also cause a significantly elevated WBC. And finally, she just pointed out that blood culture, probably not a great idea.
Yeah, I think she even mentioned that for patients who don't have complicated pneumonia, and those, if you get blood cultures, you might actually be more likely to get a contaminant than an isolated pathogen. I think that was helpful to know. What about viral testing, Brian?
Viral testing, she said, might be helpful in that negative sense again. If you know the patient has a viral illness, it might swing you away from treating a bacterial pneumonia. I like this. I think this is a very practical use for viral testing, especially as viral testing becomes more and more prevalent. The episode was recorded in 2020, and since then, viral testing has just gotten more prevalent and cheaper. It's still not cost-free, and I think we need to be mindful about that. But it does have a negative value insofar as it can make me comfortable not treating what I might otherwise treat with antibiotics.
So speaking of antibiotics, I'm going to shift gears a tiny bit and jump into the antibiotic treatment for pneumonia when you have a strong suspicion that there's a bacterial etiology. Loved this pearl there. Amoxicillin, 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 supposing that the patient doesn't have an allergy. She pointed out that actually ceftonir and other cephalosporins are less effective than amoxicillin for strep pneumo, which is the most common pathogen that you'd be treating for with the antibiotics. And so, of course, if a kid has an allergy, that's reasonable. But otherwise, amoxicillin really is the first line, and you want to be doing a high dose because it helps to overcome the penicillin binding protein from the strep pneumo.
So either amoxicillin or azithromycin, right, Sydney?
Oh, yeah. No, we should definitely not be giving these kids azithromycin. It has really poor coverage, lots of resistance to strep pneumo. So, yeah, stay away from azithromycin in most cases when there's not an allergy picture.
That was interesting that you mentioned allergy. I think one of the things that she mentioned was that a lot of penicillin allergies aren't necessarily too true, but that's a shared decision-making issue, and that's what evidence do you have of a penicillin allergy? If you do have a true penicillin allergy, cephalosporins are safe.
Kind of talking about the azithromycin, I feel like we could probably dig deeper into this than she went into on the episode, but I think it's worth kind of making a nod to mycoplasma pneumonia, which was the other common cause of bacterial pneumonia in kids. And she kind of pointed out that we don't have a great understanding of exactly what the role of mycoplasma is in causing disease. And there aren't really good symptoms or signs we can use to distinguish atypical pneumonia. And even when you have a diagnosis of mycoplasma, it's not entirely clear how much macrolides help. So just kind of recognizing the limited role for azithromycin, not necessarily no role, but that it definitely shouldn't be a first go-to.
Definitely. And I think she's talked a little bit about treatment failure. And before she spoke about treatment failure, she mentioned that maybe because we're typically dealing with a viral illness with pneumonia, that we could try other adjuncts like bronchodilators to see if that could help, and that it's not necessarily the antibiotic not being the right type of antibiotic, but just that you're actually treating or you're dealing with a viral illness, and that a bronchodilator could help versus the antibiotics themselves.
And in this case of treatment failure, sure, trying the bronchodilator is going to give you some information in terms of additional imaging. If you haven't done an X-ray, that's a reasonable time to consider doing it. You are also trying to look for complications. And that is where a lung ultrasound actually might be the right testing modality, looking for things like a pleural effusion, which we will get to shortly. But can one of you just quickly jump in and talk about discharge planning, duration of antibiotics?
Yeah, y'all jump to treatment failure so quick. I feel like a lot of these children do well on antibiotics and have been doing well on less and less antibiotics. She mentioned moving from a 10-day course to a 7-day course. And there are even studies out there that suggest as low as 3 days. I know my branch of Kashlak typically tends towards a 5-day course, which I I think is great from an antibiotic stewardship perspective, and especially from a limiting antibiotic exposure and limiting antibiotic side effects. She mentioned something that I have not counseled families on, and I think I would like to more, that the child might not be fever-free in the first day or in the second day, or even might not be fever-free at the time of discharge. They'll eventually defervesce, and following that fever curve is helpful. But if this is a big infection, it still could be causing a fever, even on the right antibiotic choice. Okay, now we can go to treatment failures. I wanted to give credit to the kids who do great on a 5-day course of beta-lactam. But Cleo, what about some other consolidative processes?
Yeah, so the types of complications from pneumonia that we're thinking about pleural effusions, like empyema is essentially just a pocket of purulent fluid. You can get necrotizing pneumonia, where the tissue itself is necrotic, a lung abscess, or even a bronchopulmonary fistula, which is a more rare finding. But I liked her discussion just about how to evaluate for these and when to consider things like you mentioned, Sydney, ultrasound versus even like a CT scan to see. And then it's not just the bacterial pneumonias that can cause the complications. She did talk a little bit about secondary pneumonias from viral illnesses. Can one of you remind me what she was talking about there?
Yeah, it sounds like things like influenza, and especially influenza, can lay the groundwork for some of the more virulent organisms and some of the more scary infections like pleural effusions or necrotizing pneumonia.
And then when you see a kid that does have some of these complications, even in these cases, there are contexts in which they can be treated in an outpatient setting with antibiotics. You're thinking about coverage for strep pyogenes or staph infections. If it's a larger effusion, she described it as like half of the chest wall or more, they're going to need admission, usually IV antibiotics, broader spectrum, further imaging, and even drainage.
Well, I'm really glad we consolidated that topic. So let's change the chloride channel and talk about our next topic, cystic fibrosis.
Oh boy. All right. So we are going to move on and talk about cystic fibrosis. At the Cribsiders, we actually have 2 episodes on cystic fibrosis. We are going to be talking tonight about episode 1 of the whole podcast series, which covered cystic fibrosis with Dr. Whitney Warren. Though, just for the listeners, there is another episode that you can listen to as well from the Cribsiders. This episode, number 1, was produced by Clara Mao, and this episode was very helpful in understanding CF, what CF would look like, both early on, but also when presenting later in life and talking about some of the treatment modalities and reasons why we treat the way we do for this episode. I really enjoyed it. One of the things that Dr. Warren discussed early in the episode was thinking about the way CF can present in different patients and the way different genotypes can be associated with different phenotypes, but also knowing that if multiple patients have one genotype, they also may look different clinically. And so just in general, this episode had a lot of good like med peds pearls, I feel like, for adults as well. And she talked about the patients who she sees who present later on in adulthood typically have more mild symptoms of CF. But how do these patients present?
Yes. Oh, I feel like when we see older patients, and again, this may become, she pointed out that this is likely to become more and more rare now that we have universal in the United States testing as part of the newborn screen. But when you see older patients that went undiagnosed, you're usually seeing people who have recurrent pneumonias, poorly controlled asthma, and then these patients or even I think recurrent sinusitis as well. And then when you do further sweat chloride testing, it'll be abnormal. Then you do the genetic testing to figure out the associated genotype.
Yes, I really enjoyed her Pearl talking about how the sweat chloride test is actually done in the clinical setting, because it's not something I routinely think about. And she was talking about how operator dependent it is, and how I guess at their clinic they have a really experienced nurse who can get anyone to sweat, and it's really successful. And so I think just keeping that in mind, that it is a more user dependent test. How about PFTs, Brian?
Yeah, I love this. Sweat chloride and PFTs are both tests where if you are in medical school, or if you're in residency, or if you're in your training to be a provider of any type, and you have a chance to watch these done, it's great to look behind the curtain. PFTs typically start around age 5, and she was talking that a lot of kids younger than age 5 just can't participate. If you are in medical school and have a chance to do a PFT, go ahead and try, and then put yourself in the mind of a toddler, and then try again. It sounds like, though, from a CF standpoint, tracking FEV1 and FVC, as well as sputum samples, are very helpful in tracking disease progression, making sure disease isn't progressing unchecked.
And then I think moving on a little bit into the treatment and things that we can help manage for patients with CF, there was a really helpful conversation about airway clearance and the different modalities and ways that we help with airway clearance. Sydney, what did you think about airway clearance?
Yeah, I mean, I think what stuck with me the most about this was just the immense burden that this disease puts on our patients and their families, and just being so cognizant of that. I mean, I am not by any means someone who's a CF specialist, but if I have a patient in primary care, just recognizing how much they're already doing to manage their disease. When you talk about mucus clearance, that's something that they are usually doing up to 4 times per day. And it's not a short process. It involves, nebulized treatments. It involves percussion. It involves inhaled antibiotics. So it's something that is kind of prolonged, can't just be done easily on the go. So just having compassion for that degree of care that is needed on a daily basis.
And she was talking about hours and hours of airway clearance per day, and that is a very large burden.
From a medication standpoint, what is airway clearance? I know we have a whole different episode of airway clearance, but it typically follows a specific pattern. Is that correct?
That's right. Yeah. So the zoomed out sort of view for this airway clearance regimen would start with nebulized albuterol before hypertonic saline. And
that's because hypertonic saline is irritating, right?
Yeah, that's right. And then it helps bronchodilate, and then you get hypertonic, which also provides hydration to the airway. And then typically there's like a percussion, like you mentioned, Sydney, elements, either vest or some other type of percussion, pulmozyme, and then inhaled antibiotics are also a part of this.
Interesting. Beyond the daily airway clearance, what else do patients with CF have to look out for?
So nutrition is something that is super important, and the nutritionists are a big part of the CF team. I thought it was really helpful to learn about that patients with CF have both a higher metabolic demand and a lower absorption, just given the pancreatic insufficiency that can be associated. So knowing that and working with a CF dietitian and taking enzymes before eating can all be such a key part of the management of CF.
And the weight doesn't seem to be just a number on the scale. It sounds like dropping in BMI, from what I heard, is associated with actually decline in lung function too.
And I think, if I remember correctly, that's just associated with the increased metabolic demand with worsening disease.
Interesting.
Yeah.
Cleo, can you talk a little bit about what we might expect in terms of the management of CF exacerbations?
Yes, so CF exacerbations are treated primarily with now IV antibiotics. So the airway clearance and the inhaled antibiotics are part of the maintenance phase, but increasing the airway clearance and giving IV antibiotics are key parts of the management of CF exacerbations. And that's where the sputum samples and the culture data that had been collected from like a clinical setting is helpful in guiding which antibiotics are used in those CF exacerbations. Typically, this involves like multi-drug regimens, often covering for Pseudomonas, MRSA, but it seems like patients have different regimens according to what they have grown in the past on their sputum samples. What is the endpoint to stopping these antibiotics during an exacerbation?
They follow actually the pulmonary function tests. And so what I learned was they do pulmonary function tests at the beginning of an exacerbation, treat with about 7 days of antibiotics, and institutions might vary based on when they retest pulmonary function tests. But if there's a dramatic improvement, then that might favor a sooner endpoint. And then if there's no improvement, then a longer course is favored.
Interesting. I think my takeaway from the management with the use of antibiotics for patients with CF was that the inhaled antibiotics are used for more of a chronic suppressive therapy, and then the IV antibiotics are used during the exacerbations as well. The conversation then went into more talking about the extrapulmonary complications of CF, and this I think was helpful from a like monitoring perspective. Like, what do we look for? There are so many systems that are involved. I think something in pediatrics that we think about a lot is like malabsorption, failure to thrive type picture, making sure that we're monitoring growth really closely. From a diabetes perspective, Dr. Warren discussed the ways that we monitor for this in patients with CF, and specifically why we do oral glucose tolerance tests as opposed to monitoring hemoglobin A1Cs. Sydney, what would you think about that?
Yeah, I found that fascinating. I think just recognize the mechanism for this. Just that because patients with CF have a faster red blood cell count turnover, a hemoglobin A1C is just going to give a falsely low level. And so you do need to use that oral glucose tolerance test. And with regards to diabetes, she also pointed out that it is really kind of, she's described it as the worst of both worlds, kind of somewhere
Right.
in between type 1 and type 2. There's both insulin deficiency and insulin resistance, in part as a result of this chronic pro-inflammatory state.
Just with neighbors to the pancreas, the liver also takes a hit, and there's a whole entity known as cystic fibrosis related liver disease. This is over my head and honestly terrifies me. This is a whole body system. It's a whole body process, cystic fibrosis is.
Right. And including like reproduction, and she talked about the need for counseling on fertility and contraception. And I think she mentioned that for some of her younger patients, maybe that's not something she dives into in the first meeting, but maybe in subsequent visits, making sure that that's addressed.
What a great place for a primary care physician to really make sure you're looking at the whole patient. And I know a lot of our pulmonologists are great about talking about some of these uncomfortable things. For a teenager, though, you have to continue to talk about all the things you would in a normal well child check, including reproduction, who they're seeing, what their plans are for the future, and encourage healthy choices.
Yeah, I think I loved the conversation about reproductive health in patients with CF because it is just such a primary care topic. And I think in particular, like when you start getting into older adolescents, having conversations about, okay, the likelihood of like that the vast majority of patients of male patients with CF do not have a vas deferens, but that you can in fact harvest sperm and allow them to have a biologic child in the future. And then for people with uteruses, recognizing that they still can become pregnant. And so making sure that you are counseling about contraception as you would with anyone.
Yeah, and similarly, as you would counsel patients in the primary care clinic on exercise and nutrition, this is also an important topic to cover in patients with CF, making sure that exercise is emphasized and encouraged and discussed at every visit. Moving into more treatment modalities for patients with CF, she talked about CFTR modulators that are really changing the landscape of treatment for CF, and that these work for now up to 90% of CF mutations, which is really amazing. And then they discussed a little bit about referring for lung transplant and the question of when to do that. I think Dr. Warren emphasized just doing that earlier so that the patient can meet with the transplant team and they may say, this is not the right time, but at least we know each other and we'll continue to follow. I think that was helpful to know as well.
I think in my head, I might be confusing our 2 episodes on cystic fibrosis because our second one goes so deep into these modulators. But knowing that 90% of patients with CF are treated with the modulators leads one to consider the last 10% and consider who's in that last 10%. And I think there's a whole conversation about disparities with that last 10% that I'll put in the parking lot. But if you're interested about that, go and check out our second CF episode that dives specifically into the modulators. All right. I don't want to sweat it too much, but I think it's time to move on to the next topic. We've got one more in snore.
Brian.
Oh, man.
I was told I had to. The last episode, and the pun will make sense, is obstructive sleep apnea. Episode 104. Our guest was Ignacia Tapia, and our producer was Dr. Crystal Nora. I love this episode. This is something that I see in primary care all the time, and that I have a suspicion for in primary care all the time. My favorite number one takeaway from this episode is how Dr. Tapia described obstructive sleep apnea to families and patients. He had a great visualization. Imagine if I came up to you while you were sleeping and put a pillow over your face, what would you do? And families will say, well, I would fight it. My heart rate would increase. Stress would increase. I've had trouble throughout all of my medical training understanding why obstructive sleep apnea is such an issue. And that highlighted the degree of stress that OSA puts on a patient. And that stress is a cumulative effect. And it happens really only overnight when the body is supposed to be relaxing. And so those muscles that are supposed to be relaxing loosen up. And then Dr. Tapia sneaks in with a pillow over your face.
And not just one time, multiple times per night.
Multiple times per hour, it seems.
Yeah, that's right. He really did a great job outlining for us as listeners and the risk factors that we should be thinking about for OSA. Primarily thinking about like tonsillar and adenoid hypertrophy.
One of the fun things about this was the idea that tonsillar hypertrophy is correlated, but only about 50% of the time. And so there are some patients with tonsils that are massive that don't have OSA, and there are some patients with tonsils that you think are middle of the road or maybe a little bit smaller than average that do have OSA. Seems like there are a lot of other risk factors beyond just tonsils, even though that's the number one thing we should be thinking about.
Yeah, like structural factors that can contribute to obstruction. Thinking about patients who have like mid-face hypoplasia, achondroplasia. Trisomy 21 is a big population that experiences OSA.
Obesity also is one that can cause OSA. In my mind, though, pediatric OSA is a little bit different, and typically pre-adolescents have more of these other risk factors. It seems like there's an even sex distribution pre-adolescence and then a male predominance in adolescence and beyond. And then the last thing that I love, the other quote that I love from Dr. Tapia is, quote, sleep is free, but that doesn't mean there are no disparities. And so when we're thinking about all of the things that contribute to sleep, and including obstructive sleep apnea, there are many things like ability to find a quiet place to sleep, to have a dark room to sleep in. There are so many things that go into being well rested. And then going on to OSA, there are so many barriers for family to get diagnosed with obstructive sleep apnea and find adequate treatment. Before we get to diagnosis and treatment, Sydney, would you remind us about some of the symptoms and how OSA presents?
Yeah, this was honestly one of my biggest takeaways from this episode. Dr. Tapia did a really great job of hammering home that in younger children, the main symptom is not sleepiness. The main symptom is irritability and behavior change. And so it's really interesting because that's one of the main questions or concerns that parents come in with their toddlers, with their school-age children is like, oh man, my child is hyperactive. My child is, acting out, and being like, having sleep apnea on your differential is just, to me, it's like that mind blown emoji. Like, oh, of course, this is something that we need to be thinking about. And so that should drive you directly into some of these screening questions. And to that point, like ADHD in kids that are diagnosed with it often improves with treatment of sleep apnea, because if a kid isn't breathing in their sleep and therefore not getting great quality sleep, it's going to be a lot harder for them to regulate during the day. When you do get into adolescence, that's when you get, okay, they're going to be more sleepy during the day. It's kind of the more typical picture that you would think of in an adult presentation. Brian, can you talk to us a little bit about what to do when you are trying to like make this diagnosis or even like think about this diagnosis?
So like you said, Sydney, you've got to start by thinking about the diagnosis, including when you have a kid who's just irritable and maybe has a little bit of snoring. There are some questionnaires that were useful screenings that Dr. Tapia mentioned, but most of what he talked about was taking a full sleep history and having that include some of these lifestyle things like if the child falls asleep independently, what the sleep environment looks like. And then my favorite, I keep saying my favorite, I guess I just loved this guest, make the sounds. Try, ask mom or dad, does the child snore like this? And then just make those sounds, make the gasping sounds. And then see if family will also often come with videos and encourage that because videos can be so helpful in diagnosing these apneic events.
I agree. I have spent some time with our sleep medicine team, and I was very impressed by the questions that go into the history and the history taking questions around us. The sleep routine, like not only I'm used to asking, what time do you go to bed? What time do you wake up? Do you snore? And I think just zooming into what time are you thinking about going to bed? What time do you actually fall asleep? What do you fall asleep with? A bottle? Are you sleeping with someone else? I think these types of questions are so important and it can really help us understand the full picture of what's going on, if it's OSA or otherwise.
And then it sounds like the full picture is actually a sleep study. That's the gold standard. Is that right, Sydney?
Yeah, I mean, Dr. Tapia did a really great, really thorough job of kind of jumping into what are all the components of sleep studies. First of all, I didn't even realize there were multiple kinds of sleep studies in my what I knew. There was the home one and then there's the not home one. But it turns out that there's different forms of sleep studies that involve different types of measurements, different lead placements, et cetera. So that was fascinating to me. And he kind of talked through what different readouts you're getting, what the process will look like. I think some really good pearls for counseling patients that is worth going back and listening to the whole episode for. When you get the report, kind of the main number that the sleep specialist is going to be looking at is usually the apnea hypopnea index or the AHI, which is graded from 0 on up. 2 to 5 is considered mild. Less than 2 is considered not sleep apnea. 2 to 5 mild. 5 to 10 moderate. 10 or more is severe. But Dr. Tapia makes the really strong point that you still need to look at the clinical picture, that, even if a kid has less than 2, if they have a picture that is really consistent with sleep apnea, it may be worth referring. And on the flip side, if you have a kid who has a moderate score but is clinically doing okay, you may choose watchful waiting as opposed to referral for surgery.
Scheduling a sleep study has been a very challenging thing in my outpatient practice. And I think knowing that, and Dr. Tapia emphasized being mindful about the challenges for families for getting that diagnosis, was fantastic. He did mention home sleep studies, but said they're not quite ready for prime time. They're working on it. And I think that's something that families ask a lot about. Can we just do a sleep study at home? I'm so ready for home sleep studies. I feel like that would be fantastic. Once they're validated, I'll use them all the time.
Right.
Once we have that diagnosis, though, there are a few different routes we can go. Route number 1 is watchful waiting. It has a great role in mild OSA, so that AHI from 2 to 5 without any other concerning symptoms, but only if we are truly watchfully waiting. It's helpful because children will grow, and so sometimes they do grow into their airways. Larger caliber airways will collapse less frequently, which kind of makes sense from a high school physics standpoint. But it's helpful to have family track symptoms, have them continue to take those videos, and then have a follow-up plan. When am I going to see you next? Let's talk specifically about symptoms. And then if it's not improving by this time, then we're going to refer you to the next step.
And I honestly thought that at that time, intranasal corticosteroids would be a helpful agent to try.
Right.
I was a little surprised to hear that we don't feel like that's as helpful as maybe I had previously thought. Certainly it seems like it helps with some of the symptoms like congestion, but it doesn't seem like they have true, like, meaningful endpoints in helping with OSA itself.
Definitely practice changing for me because I have prescribed corticosteroids intranasally for OSA for a few kids, and I owe them an apology.
Although, to be fair, it didn't sound like it hurts, and it sounds like it may improve some of the congestion symptoms. I think his main point was just that it's really not going to make the big differences that we're looking for. So I think, Brian, you're okay without going and apologizing to all your patients, and I also think that you have better things to do, like practice your snoring noises.
Oh, thank you. Okay, should I do it right now?
Yeah, one more snore.
Well, I'll do it after we describe the last thing, which is that big change for kids with OSA, which is an adenotonsillectomy, or colloquially the TNA. It's recommended for children with obstructive sleep apnea and enlarged adenoids. We were talking before we recorded that this is the most popular pediatric surgery ever in the United States. Is that true?
It seems like it. I think he did throw out that statistic. It's the highest number of surgeries for pediatrics in a year is TNA.
I guess so. And then the rest of the things that people recommend are more patient dependent, like oromaxillary surgery or implants. Some implants are recommended or at least approved for patients with specific conditions. I think trisomy 21 is worth looking into for patients or for people if they're interested. Other thoughts or feelings, or should I close us with a snoring noise?
I could use a good snoring noise. It's late.
Me too.
All right, that kid has an AHI of at least 5.
Right, that one has an AHI of father-in-law. Yeah. Well, I think we've put this one to bed.
All right, so I think we should close it out. Well, with that, this has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com. A special thanks to our showrunner, Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Dr. Brian Woolward.
I've been Cleo Rochot.
And I've been Sydney Engel. Thank you and good night.
Good night.
No snoring, okay?